I'm Dr. Harbnash Lal, Senior Eye Surgeon at Sir Gangaram Hospital and Director Delhi Eye Center. Today I'm going to discuss with you one of the most challenging cases handled at Delhi Eye Center. This patient came to us with proliferative diabetic retinopathy, cataract, and neovascular glaucoma. Neovascular glaucoma is one of the most intractable disease encountered by the eye surgeons, and the patient's eye pressure was 45 on maximum medication. And if this pressure remains like this for some time, patient is definitely going to lose its eyesight. So it is a type of an emergency where we have got to take this patient up and handle it immediately. Now I will be showing you the video of the patient. And this patient, after making the conjunctival flap, we do a light cautery of the sclera so that it won't bleed. Once the light cautery is applied, the patient is ready for making a flap of the sclera. Half thickness, limbus based scleral flap, which is nearly 500 micron deep. Two cuts are given, and after this cut reaches up to the limbus, we need to lift up this flap and go up to the limbus, and once this flap is made, the area is dried, and we need to put on a mitomycin C for better filtration. So I put on a merocell sponge between the conjunctiva and sclera, and this is placed at 3 places between the sclera and conjunctiva, and this prevents the fibrosis. And another flap is placed under the scleral flap onto the scleral bed to prevent the fibrosis there as well. Now this conjunctiva is lifted and covered, and we wait for 2 minutes for this to be effective. After 2 minutes, this conjunctival flap is lifted, these sponges are removed from the eye, and this area is thoroughly washed with the 20 ml Ringer's lactate for nearly 2 to 3 minutes. This washing is must so that this mitomycin C will not go inside the eye. And after profusely washing, now this area is ready for trabeculectomy or for glaucoma surgery. But this surgery we cannot do at present. We will do it after finishing the cataract surgery. So now after thoroughly wash, we keep the flap back and go for a cataract surgery. Now we are ready for a cataract surgery. We make a side port incision, which is very small, 1 millimeter incision. We inject the anesthetic drops inside the eye to anesthetize the iris. This patient is done without injection, so this is must. After this, we put a very thick viscous material. We go to the opposite pole, start injecting the viscoelastic. Whole of the aqueous is removed and replaced with the viscoelastic. Now we make the main port incision, which is 2.2 millimeter in size, and this incision is self-sealing. This is constructed in such a way that as soon as your instrument is out, it requires no suturing afterwards after finishing the cataract surgery. Now we try to create a round opening onto the anterior capsule of the lens. This is the most crucial step because this round opening is strong enough to withstand the pressure of the phaco machine or the turbulence created by the phaco machine inside the eye. And this round opening, if you feel that there is any problem with the needle is removed and the rhexis is completed with the rhexis forceps. As you see that this pupil is completely smaller, but still we are trying to make the rhexis beyond the pupillary border. So rhexis has to be nearly 4 millimeter in size. This is technically much more challenging. With experience, you can do that. Create a rhexis bigger than the pupil size. But now because the pupil size has become very small, surgery will not be safe. So we will inject a ring to dilate the pupil or keep it dilated. We inject the viscoelastic between the iris and anterior lens capsule surface to create a space for the Malaghan ring to go inside the eye. So Malaghan ring has got 4 scrolls. First scroll comes out and holds on to the pupillary border. It is pushed. Then the second and third, both of them go and stretch the pupil onto the either side. And finally, the subincisional scroll is tucked onto the temporal pupillary border. And once this is tucked now, this will not allow the pupil to constrict while operating. And once this is in place, we need to separate the nucleus or the cataract part from the capsule. So we inject a wave of the fluid underneath the capsule, and this fluid separates the cataractous material from the capsule. Then we create another wave to separate the hard part of the nucleus with a soft part which acts as a cushion, thereby making the three components of the cataract. One is the soft cortical fibers, second is the cushion epinucleus, and third the hardest nucleus part. So now we take a phacoemulsification machine which has got three functions. It provides the fluid inside the eye infusion, which maintains the space in the eye. Then it has got a suction. It sucks out whatever material has been emulsified. Then a strip vibrates to crush and emulsify the nucleus. We make a trench into the nucleus of the cataract or the hard part of the cataract. Like you see, the chocolate has got a crack which breaks very easily. So once we create a trench, we will break this hard part of the nucleus or the central core of the cataract into two parts. Once these two parts are created, now after making a trench, we separate and create the nucleus is broken into two parts. Now once these two parts are created, we rotate it and break it in front of the phaco tip or phaco needle. Now we will separate. This is a soft cataract. We are trying to remove the epinucleus or softer part of the epinucleus from the front surface of the nucleus and between the capsule, so that this nucleus can be easily prolapsed into the central part. All the emulsification of the nucleus has to be done at a central part, because this is the area which is supposed to be central safe zone. This is the area where there is a maximum space in the eye. Any surgery performed outside this area may have a serious consequences. So all the material of the cataractous material is brought into the central zone for emulsification or suction. Again, some of the epinucleus is removed so that the nucleus can be easily prolapsed into the central part. Now the nucleus is prolapsed and further broken into small pieces, and if required, the second instrument can feed these pieces into the tip of the phaco probe and can also be used to crush. Now we are going to remove the soft part which was acting as a cushion, what we call as the epinucleus. Hard part has been already removed, and after this epinucleus is very large, so we keep on debulking it at many places. Once it becomes a little smaller, then we again suck it and prolapse into the central part. So we keep on debulking, and once it becomes a little smaller, it can be easily prolapsed into the central part. And now it is debulked and it is prolapses into the central part. Some of the part is still left, which has to be brought into the central part to final emulsification of this. And once this is totally removed, this is now more or less in the process of getting finished off. So the nucleus and epinucleus is gone, and before we remove this port, we make sure that there is no epinucleus is left. A small chunk, this is also removed, and now we put on a viscoelastic to maintain the chamber depth. Now a little bit of cortical fibers which are attached to the capsule, which you can see are now being removed. So these are very fine fibers. They cannot be removed by the phaco tip because phaco tip is much more wider opening. So it needs a probe which has got a very small opening of 0.3 millimeter, and at the same time we need to keep on providing the fluid inside the eye. You can see the two probes. One is providing the fluid inside the eye so that the shape of the eyeball is maintained, otherwise the eyeball will collapse. And another port is the suction port. This is a suction port which is going in, which goes to from a different position. Initially it was going from the main incision, now it is going from the side port incision, so that it can easily reach to all the areas of the eye Now we inject a viscoelastic before withdrawing our infusion port to maintain the shape of the eyeball. Now we need to remove this Mallogan ring. Before removing the Mallogan ring, we put on an IOL inside the eye. An IOL is placed into the capsular bag behind the round opening which we had created at the beginning of the surgery. And once the IOL is in, we need to remove this ring which was placed to facilitate the surgery. And as you can see that this pupil is very small, and this patient needs larger pupil for doing extensive pan-retinal photocoagulation. Now we go and do the glaucoma surgery, and this is a flap of the sclera which is removed. This makes a communication between the anterior chamber and a subconjunctival space. This piece of the sclera is removed so that the communication can be established. Now we will remove the iris, and we want to do large iridectomy, and the sum of the iris which is attached over here, I cut it, and it will facilitate the easy lasering of the eye. This patient needs extensive lasering of the eye. So now we close that flap which we had created so that the drainage is absolutely controlled, and after the triangular flap is sutured back, we suture back the conjunctival flap which was created earlier on. Now this is absolutely closed. We inject a anti-VEGF to decrease the vascularization of the eye. Finally, this viscoelastic which was there inside the eye is removed. Patient is injected with the air to maintain the chamber. The side port and main incisions are sealed, and the surgery is complete. And this patient, after surgery, recovered excellent vision. While he had counting finger close to the face initially, his vision improved to 6/9, and his pressure was in the range of 15 to 16. His pressure got controlled without any medication. Thank you very much for watching the video.